Hi, it's Dr. Centeno, and thanks so much for joining us today. This is You've Got the Power. My focus here with this, usually twice a week show, if I have time for it, is to try to get patient questions answered, to cover some interesting topics as well that patients might be interested in, and to make sure that patients are educated about various choices in their healthcare, in particular having to do with interventional orthobiologics, and obviously other things that involve trying to treat the spine or peripheral joints with PRP, bone marrow concentrate, culture expanded stem cells, etc. So today we're focusing on an interesting topic, and that is I see a lot of patients who ask me about what is a facet capsule injection and how is that different from a standard facet injection, and why would one be better than the other. I also see lots of patients who get very confused by all of this, and they often go to doctors who will tell them that they're injecting this or that facet joint, let's say in their neck, 1, 2, 2, 3. And then I'll look at the notes or call the provider's office or look at their website and find out pretty quickly that those joints actually never got injected. So all that needs to be repeated. Now, the patients are none too happy when they find out about that, because they're like, wait a second, I paid for these facet injections, let's say with PRP, but you're telling me I never got them. So that's what we're going to dive into today. As usual, you are absolutely okay with asking any question you want, whether it's about this topic or another topic. And I'll start with about a 10-minute didactic going over this whole thing of what is a facet capsule injection. And then from there, we'll go into questions, again, about this topic or anything else. So I'm going to go ahead and try to get this up and running. I've got someone helping on the other end to make sure it starts like it's supposed to. And we'll start the slideshow here. Okay, so what is a facet joint capsule injection or a facet capsule injection, and how does that differ from more advanced facet injection procedures? So again, this is one I hear all the time. A patient will come to me and I'll ask, hey, did you have the upper neck joints injected? Let's say it's a craniocervical instability patient. And the patient will say, oh yeah, sure. I went to Dr. So-and-so and he told me that he injected 0, 1, 1, 2, and 2, 3. And I go through the notes, and sure enough, those joints were never, ever injected. And oftentimes it's this issue of the difference between a facet joint capsule injection and more advanced facet injection itself. So we're going to go into that today a little bit. So the facet joints are these small finger-sized joints that occur 2 at each level. And you can see they're in the neck here. So this would be the 2, 3 facet joint there. Here on the right, this is the 4, 5 facet joint there. Then we've got these thoracic facet joints here. And then we've got the lumbar facet joints down there. So in your low back, you've got facet joints at every level. In your upper back, you've got facet joints at every spinal level. And in your neck, you've got facet joints at every spinal level. Now, these joints can be injured or get arthritis, and that can lead to chronic neck or back pain. They can also be injected with orthobiologics like PRP, for instance, or bone marrow concentrate or other things to help promote healing and to reduce pain. So injecting the facet joints in patients with chronic neck and back pain is pretty common. And obviously, focusing on regenerative medicine, we don't like to do that with high-dose steroids because that can destroy the cartilage in the joint. Our focus is stuff that may be able to help the joint. Now, as an expert in this area, I commonly see patients who tell me that they had these specific facet joints injected. And as I said, when I go and investigate that, that's really not what was done. And in fact, instead, what was injected was the Facet Joint Capsule or the Facet Capsule, or at least that's what the notes say. And then I've also had patients ask me this question, well, what's the difference? So there are really two very different levels of spinal injections when the term a facet joint injection is used. Meaning if you hear a clinic say, we inject the facet joints, you're going to get two different things. Many times you'll get this, and that's an actual fluoro-guided and contrast-confirmed facet injection. And I'll talk about what that is. But also equally, sometimes you'll get this, and that is not what's on the left. That is placing a needle near the back of the facet joint. And that's why it's called a facet joint capsule, because that's kind of where the facet capsule lives. But you can't even do that with what's done here, meaning it's kind of just park the needle at that spot. And that can be done blind, even though that's pretty dangerous in the spine, or with guidance like ultrasound or even fluoroscopy, but it's not what this is over here. So let's start with the standard of care when someone says they're performing a facet injection. The current standard of care is what you see here and here. And that is that a needle goes into the joint itself. There's a small amount of contrast injected that you can see, and then that's chased with the injection. Now, this is called contrast confirmation and fluoroscopy. And the reason for doing it this way is that if you're off just a millimeter in the wrong direction, the stuff never goes into the joint. And so this is not a trivial injection to perform, and it needs to be performed by someone who has a lot of education in the spine about how to get inside this joint, because these joints can be quite challenging sometimes to make sure you're inside them. So the needle here goes inside the joint. And then, like I said, you inject that contrast, and that contrast determines for sure that you're inside the joint. And then you, through the same needle, inject whatever it is you're going to inject, let's say PRP. And it's not trivial, meaning that, this takes a long time to learn how to do well. And it's something that can be done by a specialist physician, but not your average family doctor or burnt out ER doctor who's doing prolotherapy, etc. Now, oftentimes, physicians that are doing prolotherapy will use this technique that I'm going to describe, and they call that injecting the facet capsule. And literally all they're doing is they're placing the needle kind of in here, and they're not trying to get into the facet joint, even if they're using X-ray guidance or ultrasound guidance, because they don't have that level of training. And they'll also usually inject some midline ligaments. That's the prolotherapy part, or ligament prolotherapy part. And so what's the purpose of injecting kind of on the bone there? Well, that's called a Hackett point, and that comes from one of the originators of the prolotherapy technique. It's where little muscles attach. So those areas can be painful, and it's not totally worthless injecting them, but it's not injecting inside the facet joint. And for some reason, at some point, this went from Hackett point, which is the most apt description of what that is, to this concept of facet capsule. And I think it began to change right around the time that more advanced practitioners came in and started injecting inside these facet joints using contrast confirmation. I think the prolotherapists felt a little threatened by that, so they wanted to describe what they did in some way that kind of crossed over with the Venn diagram of an actual facet injection, even though they weren't doing a facet injection. And there are substantial differences in training here. A real facet injection, and remember, at our clinic, we educate fellows on this. It's generally a fellowship or extensive course training and significant hands-on proctoring. So how long does it take to get good at injecting facet joints? The simple ones in the neck and the back, we're not talking about really hard ones like 0, 1, and 1, 2. it takes at least a year to get competent at this. And you're not really hitting your stride until you get to 2 to 4 years out. And then at that point, you're really good at this, assuming you're doing a lot of it. And then in order to do the prolotherapy facet capsule technique, it's just a weekend course. So these are two vastly different levels of providers doing these things. So why inject the facet? The pain is generally generated by the damaged parts of the internal joint. So the injectate has to go into the joint. And then the other twofer that you kind of get is that many facets leak from the facet joint to around the local spinal nerve, or what we call epidural. So you also get this epidural effect. So if you put PRP, for instance, in the 6-7 facet joint on the right in the neck, it's going to leak around that nerve there at that level, which is likely going to help that irritated nerve as well. So you kind of get a twofer. You don't get any of that if you just inject back along the bone, or what's called a facet capsule injection. So again, if I'm just injecting not in the joints, but kind of on the bones here or these Hackett points, what is that really doing? Well, it can be helpful when there's little muscles that attach to those spots, and those muscles have painful tendons. So it's not completely worthless at all. It's just not anything like doing a real facet injection, despite this confusing term that a lot of the prolotherapists have added of saying they inject the, quote, facet capsules. So in conclusion, don't be fooled into believing that a provider can inject your facet joints just because they use that term. You should always ask if they use fluoroscopy and radiographic contrast to confirm where they are. And if the response comes back, oh yes, our doctor always does it with fluoroscopy and puts contrast in to make sure that they're in the right joint, then good. But if the response comes back, no, we inject the facet capsules, then run, because you're not really getting what it is you think you're getting. And I've seen patients pay thousands of dollars to have their facets injected. I look at the notes and they never got anywhere near those facet joints. So it has to be done all over again. So just a word to the wise there. So let me take questions now. I'll stop the sharing here. And we will go to a bunch of questions that popped in here. Regenexx, minute advanced by Harry Winston. Maybe is this procedure available at Algo Cells in London? Sure, they should be able to do true intra-articular facet injections there. So you're going to get the more advanced version there, not a facet capsule injection. Diana, hi, Dr. Centeno. Thanks for all your videos. They give me hope, and I appreciate the evidence-based explanations. On left open mouth lateral bending, I have mild overhang, 2.5, with asymmetrical periodontal spaces. The left periodontoid space is accentuated, measuring approximately 5.5. The right is 2.5. The CAT study mentioned the previous video concluded that asymmetry and greater than 2 millimeters of overhang is accurate identifying trauma injury. So important to note from that CAT study that if we use 2 millimeters as a cutoff, and the goal was to try to place people into one of two boxes, either traumatic neck injury or just normal, meaning just someone walking off the street who's never had any neck problems, then it's about 2/3 accurate if we use 2 millimeters. But if we increase that to 3 millimeters of overhang, then that confidence interval, meaning how sure we are that that's a real problem rather than just a normal variant, goes up to 95%. That's kind of, you're kind of sort of in between those two, where what we're looking at is likely abnormal, but not as certain, for instance, as it would be if it were 5 millimeters. Regenexx, I'm in advance by Evelyn Williams. I was told that my C2-3 joint capsule is torn, and it is possible if so, is it fixable? You know, there generally isn't a reason to fix a facet capsule because they don't provide a lot of stability, meaning that we see a lot of torn facet capsules. So for instance, in pretty much almost all patients, regardless of how much they hurt or what's happened to them, by the time they get to be in their 30s, the 4, 5, 5, 6, and 6, 7 facet capsules are all torn. So that can be just part of the normal degenerative cascade. That could indicate trauma. But since the facet capsules don't provide a lot of stability by themselves at those levels, then probably not a big deal other than to know that it's there. And it may be something that tells us that there's some additional trauma that happened at that 2-3 joint. Phil, what is the optimum frequency to repeat posterior PRP injections into facet joints and surrounding ligaments? Generally, we're looking there at 4 to 6 weeks before we repeat. Different than something like a PICL, where we're really looking at 3 or 4 months. Francis, I'm considering a treatment with expanded stem cells to treat RA systemically in several joints locally. The clinic works with a cell bank that illegally expands cells from fat and ships them on demand. The advantage is they are much cheaper than the clinics doing it legally out of the US. I'm aware that they could be enjoined at any time. Other than the likelihood of losing my investment in the cells, what are the pros and pitfalls of working with such an outfit? And I think some of it got cut off, but I'll answer what I have here. The biggest the biggest pitfall would obviously be making sure that they're actually doing what it is they say they're doing. Meaning culture expanding cells is not trivial. I've been doing it since 2005 for clinical use. And we have a clinic that we licensed in Grand Cayman to culture expand cells. So it takes significant expertise to do that. And you would probably want to make sure that you're actually getting what it is they say you're getting. The other problem is that you have to have a lab on the other side to receive the cells. Otherwise, the cells are going to be substantially beat up. So what I mean by that is if you want to take cells that are otherwise cryopreserved, and which is what they're going to have to do on their end. And let's say they were correctly cryopreserved. In order to get those cells, let's say across the country and to a clinic, that clinic would have to have a recovery culture lab. So that would mean that clinic would have to place those cells into a controlled rate thaw. And then from a controlled rate thaw, they would have to go into a recovery culture for several days in order not to kill a significant portion of those cells. If the clinic is just warming up the cells in their hand and injecting, you're going to lose a lot of cells because of that severe quick temperature change. So not sure if all those things are in place, but like everything else in this world, you usually, not always, but you usually get what you pay for. So if you're trying to work with a clinic that is breaking the law and it's cheaper, probably not a great thing. You might get lucky though, best I can tell you. Marie, can patients still get muscle spasms and neck pain from instability in lower facets below C2? Do these facets still impact stability? We certainly see people with instability, usually due to bigger ligaments being involved, the anterior longitudinal ligament, the posterior longitudinal ligament, the supraspinous, interspinous ligaments, the intertransverse ligaments, etc. And then the facets get beat up. And so the overall instability both beats up the facets and causes spasm for sure. Pia, I heard that Schultz, both you and Schultz will be away in the fall. Who at your clinic will do posterior while you're both away? Yeah, Pia, we have doctors there who are very experienced in doing the posterior injections, not so much the PICL. That's pretty much limited to Dr. Schultz and myself these days. But when it comes to posterior injections, shouldn't be a problem. Phil, what specific radiographic contrast agent is used? We will usually use Visopaque because it's isotonic in those joints, and the goal is to use as little radiographic contrast as possible when you're doing orthobiologics. Marie, if you have pain at that Hackett point, can a facet injection capsule still improve that pain and reach the same goal? Sure. Like I said, it's not a totally useless injection. Injecting along that bone where the tendon attaches, if you have pain coming from that tendon, can be helpful. But if you've got pain coming from the joint, it's not going to do anything. So that's sort of the problem that I'm relaying here. So it's not a totally useless injection. It can provide some relief, but you're just not really treating anything to do with that facet. You're just treating that tendon. Diana, with overhang on both sides, for example, mild 2.5 asymmetry, but symptomatic, wobbling head, balance problems, headache and movement, nausea, pus, is it possible to get enough stability from injecting the facet joints C0 through C2, or are the injections there mainly for pain relief? If you typically have patients try the upper facet injections, or will you typically have patients try the upper facet injections before PICL? So yeah, a lot of that depends on how much instability there is. If the person has significant instability, so 2.5, again, as we talked about before, is kind of right on that edge between being certain that or being highly likely that the instability is causing pain or symptoms, then we will go and we'll start with the PICL. Now, if it's thought that there might just be more mild instability, then we can do posterior ligament injections with those facet injections and start there as well. So a lot of that depends on how certain we are about the diagnosis. If we're very certain about the diagnosis, and that's not only imaging, that's going to be imaging how the person got that way, meaning the mechanism, what their current symptom complex is, and whether that matches CCI, response to treatment, or response to aggravating factors like headache with movement. All of that goes into making that diagnosis. And then the more certain ones go directly onto PICL, and the less certain ones, or the ones that want to take a half step before PICL, really up to the patient, usually go on to posterior injections to try to get more information. Ravati, can the unstable hypertrophy in the neck be reduced with PRP? If yes, where would you inject? More, I don't think reduced. I think the goal, so just so that everyone knows what we're talking about. So the uncinate process, this is probably a good one because I don't think people know too much about this or have heard that term. So I'm going to pull that up and share my screen here in just a second. Okay, so uncovertebral hypertrophy, it's also called. So there's the disc up front here, and then off to the side of the disc is a little raised area called the uncinate process. And let's see what this one looks like. I'm trying to find some good pictures for you here. And so when that becomes arthritic, and again, it's not in the disc, it's going to be right on the sides of the disc here. When that becomes arthritic, it's called uncovertebral hypertrophy. So as far as making that arthritic uncinate joint or process get smaller, if that's going to happen, it would have to happen through stabilizing the whole cervical spine. But I doubt that injecting it directly with PRP is going to dramatically reduce its size. The goal would be to try to make sure it doesn't get much, much worse. Deanna, can patients get worse with baseline from injecting PRP into these upper facet joints? Is this common in your experience? Other than accidentally hitting the vertebral artery, are there any other bad complications from injecting upper joints? Thank you. Any patient at any time can get worse with any procedure, whether that's surgery or a facet injection, et cetera. How often does that happen with PRP into neck facets or upper neck facets? pretty rare on a permanent basis. I'd say much less than 1% of the time. And generally, those patients are what I would call fragile eggs. So they have central sensitization. So these are the same patients that if they move their neck the wrong way, they're going to be down for 2 months. Or if they get a bad adjustment, they're going to be down for months. Or if they get an overly aggressive massage, they're going to be down for 2 weeks. It's mostly seen in that fragile egg population. And then I think I've talked about this quite a bit, but just to review, injecting those upper cervical facet joints is a high art that very, very few doctors do on a day-to-day basis. So we would use digital subtraction angiography to make sure we're not anywhere in that vertebral artery. And that doctor that's doing that has to have both a lot of experience in injecting that, but also use DSA. So that's the biggest one that's different from injecting the upper cervical facet joints. In addition, if you were total Yuts, it's certainly possible to inject the spinal cord, which would be a bad day for everyone, but someone using CR fluoroscopy with significant skill and experience obviously wouldn't be anywhere near that area if they're doing a proper facet injection procedure. But not too long ago, and you may want to go back maybe 5 or 6 videos, I did a whole hour on a physician's assistant that was trying to use ultrasound to inject these upper neck joints and was dangerously close to putting the needle into the spinal cord. So definitely something to be careful of for sure, and make sure that that person knows what they're doing. Ryan, do you place these injections under local or full anesthesia? Usually I'll inject my patients under IV anesthesia where they're sleeping. But you can also do them straight up as well, meaning straight up would be maybe just some local and then inject, just as long as you're not the kind of person that's going to be moving all over the place. Luann, do you recommend stem cells? When might they be available in the US? So Luann, we have a same-day procedure that contains autologous, meaning the patient's own stem cells. That's bone marrow concentrate. So they're available right now. If you mean culture expanded and isolated stem cells, I still think we're years away from for that being widely available in the United States. Phil, it's been said in forums that the posterior joints and ligaments can provide up to 30% of the stability needed to avoid CCI, with the major stabilizing constructs being the alar transverse. Is this true? In which case, presumably mild CCI might be dealt with just posterior injections. Phil, I think a lot depends on what it is we're talking about specifically there. So this might be a good time to kind of bring up here transverse ligaments. So let's look at that one. So the transverse ligament here. So I'm going to copy that, and we're going to throw that into that facet joint lecture just so I can draw on it, so we can all see what I'm talking about here. So what I'm trying to get at here is it depends on which ligaments we're talking about. And specifically, there are certain ligament patterns where that's more true than others here. So let's go ahead and stop that, share the whole screen. Okay, so here we have the transverse ligament, which is here. And this is going to be C1 or the atlas. This is going to be C2. This direction is the front or anterior. This direction is the back or posterior. So if our concern is that we have this space in here, the atlantodental interspace, opening and flexion, meaning when you look down, then part of that is going to be stabilized by the ligaments back here. That's going to be the nuchal ligament. and parts of the vertebral ligament. So that's a posterior structure. You can certainly tighten that down from the back if you do very, very specific injection work under guidance. However, the other bigger part of that obviously will be determined by the transverse ligament here. So you can certainly move the needle by doing some posterior injections back here. Now, if we're going the other way and we're talking about things are moving side to side, like a C1, C2 overhang, much, much harder to do. You can inject that posterior. You can inject also the ligaments way out here, intertransverse and AO ligaments, although I rarely see those injected at all in any kind of posterior prolotherapy because you've got the vertebral artery sitting right here, and no one that doesn't have digital subtraction angiography wants to get close to those. So the answer is yes. It depends on what it is you're trying to do. It would tend to work better if you had flexion instability at C1, C2 where that ADI is opening, but you're still eventually probably going to have to inject that transverse ligament, although in some patients you might not need to. So it depends on what it is we're treating. It's possible to start feeling stronger 2 months after PICL, or does it always take longer? Certainly possible, yes. I mean, people heal at very different rates. Younger people tend to heal at quicker rates. Older people tend to heal at slower rates. So we certainly have seen people who start to get improvement at 2 months. Specifically, TC, OTC in context of CCI is a constant hot topic. Tentatively watched 2 of your vids in this topic, but don't believe the specific question was brought up. Many in the Facebook group report personal cases of increased new symptoms post-PICL, and many of them report relief with listen, Oleg, I think I'm not a big believer, as we've talked about, in tethered cord or occult tethered cord, because we're not talking about tethered cord. Tethered cord has a very fixed definition in medicine and in neurosurgery, and that's where something is actually pulling that spinal cord down, and that's easily visible on MRI. Very, very quick to make that diagnosis. Any radiologist worth his salt can make it in 30 seconds or less. What we're really talking about is a occult tethered cord, and the idea not that the cord is tethered, but that it's somehow being yanked on. So there's certainly a belief, I understand, in this ME/CFS community where they believe that tethered cord is the cause of their symptoms. But I've seen as many severe complications of tethered cord surgeries. I mean, we're not talking about increased symptoms. We're talking about fully disabled people from the surgery at this juncture than I can count. So I'm not a big believer in that concept. As we've talked about here, I think lots and lots and lots, it's a certain possibility that if you're that kind of fragile egg patient who is sort of completely disabled, spending most of their time in bed, I think we talked about this just a few minutes ago, a massage will knock that person out for 2 weeks. A bad adjustment might take them out for 3 months. Then you're more likely to be in this category of patients who might report some sort of new symptoms. Do I believe that the vast majority of that small group of people are going to somehow magically get better when they have their occult tethered cord? And I'm putting that in quotes because there is no accurate way in which to make that diagnosis at this point. After they get their cord cut, I don't. It's not something I've experienced so far at all. So, and it doesn't even make a lot of sense. And you need to know, obviously, if you take 1,000 neurosurgeons and ask them that question, 999 are going to tell you that a occult tethered cord doesn't exist. So, hard one for me to wrap my head around, where we have this problem that most neurosurgeons won't touch with a 10-foot pole, that we've got just a select few neurosurgeons that are doing these detethering operations. and where I've already seen huge numbers of patients who just don't have new symptoms after their occult tethered cord, but they're permanently disabled as a result of the surgery moving forward. So that's a hard one for me to swallow. Andres, Dr. Centeno, what do you think about accelerator? They say the stem cells here in the States is stem cell light. I believe Dr. Colombo spelled that right. Yeah, Andres, I think it's amateur hour personally. What I mean by that is that, and this is not only the case with by accelerator, it's the case with any South American, Mexican, what I would call banana republic clinics. And the problem with that is that U.S. doctors aren't permitted to be licensed down there in banana republics. Very different than, for instance, Grand Cayman, where they encourage U.S. and Canadian doctors and European doctors to come there because they don't have a big enough medical care system by themselves to support the training of those sorts of new doctors. So they're happy to have well-trained European, Canadian, or U.S. doctors down there. That doesn't happen in South America. That doesn't happen in Central America. That doesn't happen in Mexico. Those places keep U.S., Canadian, European doctors out. So you're kind of left with what I call the yokel locals or the local yokels. And those guys generally don't have the kind of training that we're talking about here. So you kind of get into this situation where you get a lot of blind injections, where you don't get doctors that can do these things like we're talking about here, facet injections, et cetera, et cetera. Deanna, is there asymmetry? But if there is asymmetry, but no overhang, does this pattern tell us anything about transverse ligament or just the alar? Yeah, Deanna, I think what you're talking about is more rotation of C1, C2. Now, it's certainly possible that there are types of rotation-based instability, but a DMX is probably not the best way to see that. A better use or a better imaging type would be rotational CT scan, looking at excessive rotation between C1 and C2. So that's one of the areas where DMX is not going to be the best thing. Does your clinic do IV stem cells? We do not, Andres. We would not be the place to go if you're counting on IV stem cells. There's a 97% pulmonary first pass effect if you give someone IV stem cells. So just so that we're clear, what that means is if I hook an IV up to you, even though that's really easy for me, right? I don't have to pay a $500,000 a year physician subspecialist to put the cells specifically into this part or that part of your body via X-ray ultrasound guidance. All I have to do is, frankly, is to pay a really cheap medical assistant to stick a needle in your vein. So it's hugely profitable, but we don't offer it because 97% of those will end up in your lungs, meaning that your body ends up filtering out those cells in the lungs. It's called the pulmonary first pass. And then, for example, if we were trying to get those into your brain, which is what a lot of these IV treatments were done or are done for, only about 1 in 10,000 to 100,000 of those cells would ever end up here. So it's an incredibly inefficient way, but extraordinarily cheap and profitable way in order to deliver cells to someone. So no, we don't do anything like that at all. Liam, in regards to prepping for a first PICL, what are some things a patient should work on to make the procedure as smooth and safe as possible? I know low inflammation diet and no opiates, THC. Yeah, so I think the kind of things you're looking for, Liam, there as you bring up, trying to go on a low inflammation diet, which is usually low carb, natural foods, whole foods, rather than processed foods, etc. And then you can do other things like obviously THC and CBD, as I've talked about here many times, can dramatically increase your anesthesia requirements. Most of the time that's not a problem, but sometimes that will be a problem, meaning it'll make it hard for us to get the procedure done, or much harder, because it's much harder to keep that person asleep at the appropriate level. Another one is low dose naltrexone, we've noticed has the same effect as THC, So that's another one. And then obviously be as active and healthy as you possibly can leading up to your procedure. Now, for some CCI patients, that's going to be really hard to do. So they may not be able to do anything there other than improve what they eat. Another thing which goes on with the diet is to reduce your weight. Restrict your calories, get your weight down. That's another thing you can do to reduce inflammation. So for instance, if you're 40 or 50 pounds overweight, get down to 10 pounds overweight, or try to become your normal weight. That's another thing that can really, really help. It's true that stem cells we get injected are in the thousands, why not in the millions? Yeah, Andres, I'm not sure what you're talking about there, so I'll need to know more information there as to which you're talking about. Bonnie, is there anything you offer at your Grand Cayman location that you're not able to offer here in the US? Yeah, Bonnie, the big difference down there, as I think I was talking about before, is that cells can be culture expanded to bigger numbers. So if there are many, many more places that need to be injected, that's one possibility down there. So that's really the biggest difference. So sometimes that's an application where we need more cells, or that's someone who has 6 or 7 or 8 different areas that need to be treated. That kind of thing. Andres, is true that here in the States, the cells we get injected are in thousands, not in the millions. Not sure what you were talking about there. You may be referring to bone marrow concentrate, perhaps. But I'm not quite sure clinically how that's relevant for anything. Meaning, let's take, for example, let's come up with something here as an easy example, something we can see on MRI. So let's say an ACL tear in your knee. If it's a small ACL tear in your knee, a platelet-rich plasma injection will get it done in our clinical experience, meaning if we put that into that ACL using X-ray guidance with contrast confirmation, we can usually get that ACL to heal on a follow-up MRI. So that's a smaller partial tear in the ACL where we can see something healing on the follow-up image. Then if we've got a complete non-retracted tear, bone marrow concentrate, we'll get that done. And there wouldn't really be much advantage to going down, taking the person down to Grand Cayman to get to a higher number of cells in that clinical application. Now, for a very specific clinical application, such as, let's say, hip osteoarthritis, that's sort of moderate plus, if you will, that's an application where having more cells would make a difference. And so we'll take that patient down to the Grand Cayman site in order to treat them there. But for most of what we do, clinically, we're not talking about anything here that makes a hill of beans difference. But there are times we do take patients down to Grand Cayman, usually, and that's where we culture expand the cells. Usually it's because there are lots of spots that need to be treated, and that person really wants to only get one thing done. Let's see, I think a lot of this got repeated here. Francis, lab claims they thaw the cells properly in advance and ship them overnight. Not going to work, really, simply because you shouldn't have cells hanging around at that kind of temperature for that amount of time, especially if they're culture expanded cells. So as an example, we do studies, or we have done studies in the Grand Cayman site where we have a timer that comes with every single dose of cells, and those cells are taken out that same day, and they're not out of culture more than an hour or two before they're back in that patient. If that timer for some reason gets to 2 hours at a refrigerated temperature, we're starting to get concerned that we're losing cells. So the idea that you could put them in something and ship them overnight, which might take 24 hours from the time that you actually get them out of culture and to the time they make it back into a patient, we would never do that because our max is 2 hours. So 24 would be completely unacceptable. You'll lose a substantial amount of cells. In addition, shipping cells is not trivial because what happens to packages is that packages get put in the unpressurized part of the plane underneath. And you know that if you've ever traveled on a plane, and sometimes you get your luggage and it's cold. Well, it's cold because that bottom part of the plane isn't heated. And that bottom part of the plane, they don't bother to pressurize. So you would have cells exposed to some severe temperature changes down there, in addition to pressure changes. So you'd have to actually arrange an extremely special transport, which we've looked at doing, and it's not trivial, meaning that DHL, FedEx, they're not going to want to touch this because they don't want the responsibility of what happens there. So you'd literally have to have someone sitting up. Easiest way to do it would be have someone sitting up in the plane in the pressurized and temperature controlled area, but you'd still have that problem of cells going beyond that 2 hour mark into at least 18, 24, something like that. Way too much. Ben, when will more research be released regarding PICL outcomes? Yeah, I think I updated everyone on that not too long ago. I saw some of the preliminary information, and now what the team is doing is pulling it apart for the EDS versus non-EDS second look. We looked at that last time we did this. So I think I had said that we're probably talking about the end of summer would be my guess. So we're coming up on August 1 here. So perhaps by the end of this month, that team is working on a lot of different things. They've got a lot of different balls in the air. So, but they are working on it for sure. Conrad, flexion extension of my neck today. Could this show an opening of the ADI? When flexing my neck back and forth, the tech actually said, wow, don't bend it that far, which is concerning. No, Connor, I think you did what's right. You want to bend it as far as you can. Now, obviously, you don't want to hurt yourself, but if you can get it that far without sort of doing any very severe damage to yourself, then more motion is better. Now, the techs don't like it because frequently they'll have to change the position of the X-ray unit, and they've also been counseled and learned through the years that if patients move too far and they get injured, the complaints get reported, et cetera, et cetera. But you want to move as much as you can. So if you've got flexion extension x-rays, happy to take a look at those. Yes, that flexion could show an opening of that ADI. Zach, good morning. Is it correct to think Picl causes damage and makes your body heal on its own, whereas PRP gives your body the nutrition, growth factors, et cetera? Yeah, the difference between Prolo and PRP is Prolo is micro damage to initiate healing. So if you've ever heard of wound debridement, that's kind of like what Prolo is. So wound debridement if you have a non-healing skin wound, the doctor goes in and kind of roughs it up a little bit and gets it to bleed, pulls out some of the dead tissue. And if you do that a couple times, you can get a non-healing wound to close. That's a skin wound. Prolo does that chemically. It initiates a small amount of injury in those tissues, and that causes a brief inflammatory healing reaction. Now, PRP is different. While it also causes some level of inflammation, it also has growth factors and other things to ramp up the local repair. So, as I often say, Prolo is great, for instance, in tightening ligaments, but it takes a lot of injections usually. PRP, generally half that. Catherine, I've been having issues with my knee and low back for years. Past 1.5 years, the pain has impacted my ankle area as well. MRI of the ankle shows no problems. Knee is not bone on bone. Had meniscus surgery 8 years ago, and now have arthritis behind the patella. I've done PRP and stem cells in Dallas and Broomfield, and convinced that most of my pain in my low back and down the leg and at the top of my ankle is nerve pain. Yeah, so Catherine, that's not uncommon, where the nerve overlaps those kinds of pain issues in the knee and or ankle. And so I would agree with you that that's a reasonable thing to be considering. Obviously, getting on a telemedicine, looking at the MRI of your back, and then trying to map that to those symptoms would be the next step. But I think that's a super reasonable thing to be thinking about right now. Kesley, how do you determine who's a candidate for complex higher dissection of the ALCAO plexus? We're not doing complex higher dissection of ALCAO yet, given that it just came on our radar last week. So that's probably not going to happen for a while. And it doesn't necessarily right now change much, meaning the goal is still to treat the instability, but there's certainly the possibility of doing a higher dissection of that area at some point in the future, as soon as we determine that the risk benefit makes sense for that person. Ben, the Facebook group talks about a lot of patients not seeing relief until the second PICL treatment. That the first just provides a foundation. Does that reflect what you see? Ben, I think as we discussed before about this, the answer is maybe. What I mean by that is that it's only been fairly recently, and with any significant degree this last year or so, that we've allowed patients who didn't respond to the first to proceed to a second. And generally what we'll do there to confirm that that's what's happening is we'll have them repeat their DMX and see if, for instance, let's say their overhang got better. So if it got better by 25%, let's say, and that looks like a very real finding, meaning the angles are the same, lateral bending, etc. We will then say, you know what, you're probably in that situation where we have to get this tighter to really move the needle. And so I think that's a reasonable thing to be thinking about. I don't know that we see that enough yet because we just started opening up these floodgates not too long ago. So I'm hoping that's what it is we're going to see. And obviously, if there are patients who are reporting that, that's all good. But you also have to realize both on the positive side and on the negative side, we tend to get to see all the people that walk through, some of which are on the Facebook group, some of which are not, some of which might be more shy about what they post than others, et cetera, et cetera. I know I'm on a lot of Facebook groups and I see I'm not shy to post at all, but I see that, the group has 500 members and there's only 40, 50 people posting on a regular basis, that kind of thing. So be a little careful both on the positive and negative side there. But yes, I think that that makes sense to me right now, but I think it's a little too early to say for sure. So that's what we're doing. Marie, what ligaments are most involved in extension? If you mean in the cervical spine, it's usually the anterior longitudinal ligament there, and then the ligaments that are between the atlas and the skull up front. That could include the anterior occipital membrane, the SAAOL, etc. So there's a bunch of ligaments up front that would be involved in limiting or controlling extension. Is there many complications of meningitis, teratoma, or bone tumors? No. In fact, we've done the largest orthopedic mesenchymal stem cell safety study in the literature right now, and there were no complications of teratomas, bone tumors, increased cancer rates, or anything like that from using either culture expanded mesenchymal stem cells or bone marrow, and specifically nothing in the world of meningitis with regard to PICL. Deanna, for a recent set of spine x-rays where my head was in extreme range of motion, made me flare up severely with balance issues, wobbling, nausea for almost 2 weeks is an example of the central sensitization. It's certainly an example of what I would call fragile egg. And what fragile egg to me means is that patients who have to live in a very, very, very specific way not to constantly flare up their symptoms. So those are the patients that are much, much more likely to have a significant, rougher recovery and or much more flare up with something like PICL. So that's the that's the category I'd put you in for that, for sure. Kesley, we expanded what you mean by a patient being permanently disabled from a tethered cord surgery. Oh, God, I've seen more than I can count at this point. Let's see. One patient who had an initial tethered cord release that somehow didn't change symptoms, then met another surgeon who said it wasn't done right, so she had a second surgery, ended up with no dura in the back of the spinal cord and spinal canal, and has a chronic cerebral spinal fluid collection in the muscles in the low back, and now has all sorts of new problem symptoms related to all of that. We attempted to treat it, but the hole is just too big. So that's got to be probably treated with a duroplasty. It may actually be impossible, because by the time you do a duroplasty, you will have destroyed all of the stabilizing muscles in that area. So at the end of the day, there's really no way to fix that person. It is what that is. And we've got sort of a case series of patients who had tethered cord releases pre-PICL. I don't think they were thinking of PICL. They were more thinking that that's what they had, and got much, much worse, became disabled as a result. And now we are obviously a little bit reticent about even doing PICL in that patient population. I've turned a couple of them down because there's just too many unknowns as to what's going on. So listen, I know this is a hot topic. There's a lot of people getting it done, but at the end of the day, it's a very big deal to cut the filum terminale in your spinal cord. It will permanently change the biomechanics of how that spinal cord moves. And since we don't have a way to diagnose with high levels of certainty who has a occult tethered cord and who doesn't, meaning urodynamics does not cut it at all, we really can't tell if that's what your problem was until we cut the anchoring system for your spinal cord and see if it helps. That's a little bit like, the problem with having Chiari malformation, and the concept being that it's entrapped back here. There really isn't a test that can be done that can accurately tell whether or not that's causing your symptoms until a hole is carved in the back of your skull to see if your symptoms go away. Obviously, once that's done, you can't go backwards on any of that. You can't reattach your spinal cord. That is what that is. You can't, put this back. That is what that is. Andres, do you guys do a holistic approach when injecting? Like, you inject the whole back of the neck so it can heal as a unit, everything at once gets strong? Yes, Andres, we've always done that for sure. So that is what we do. Andres, yeah, BioAccelerator is not an American clinic. The clinic is actually down in South America. And again, the problem there is what I said is you get the local yokel, meaning that as a U.S. doctor who's board certified, I can't, for instance, get a license in Panama. I can't get a license in Mexico. I can't get a license in Colombia. Those doctors there have prevented U.S., Canadian, and European doctors from getting licensed. Different than in the Caribbean, where all of those islands welcome U.S. physicians, Canadian physicians, physicians from Germany, UK, etc., because they need the help. So it's a completely different system. Connor, for someone with systemic and progressive ligament laxity, a couple IV stem cells work to help stabilize his damaged tissues. Nope, doesn't work that way. Regrettably, it'd be great if it did, right? If it did, I could fire all the doctors in my clinic. That would save me tons and tons of money. And I could just have a bunch of MAs sticking people up to IVs all day. We could run 10, 20 at a time. It would be great. I mean, it would be awesome. From a financial standpoint, it just wouldn't work. Meaning at the end of the day, those cells will end up in the lungs, and a lot of the areas we're talking about with regard to damaged tissues have poor blood supplies. So those cells have to hitch a ride into the area, and they're not going to hitch a ride into the area if there's no blood supply or there's poor blood supply. Oleg, understanding your position on OTC, but if someone gets PICL for CCI and gets new worse lower body symptoms and other ones related to TC, well, that's the problem, Oleg. We have no idea if it's related to tethered cord. Again, you're thinking like, or at least too simply. So for example, let's say someone gets treated here and they had a SI joint instability issue. And because they're more active here, their SI joint instability gets worse. Hence, their lower extremities get worse because that's common in SI joint instability. So that's a much more common occurrence than someone having a occult tethered cord. So again, I think you're thinking about it all wrong. For those small percentage of patients who are fragile legs who are in that situation, I wouldn't advise they get their spinal cords cut. Certainly not until everything else has been investigated, because that's a one-way street surgery. You can't go back once you do that kind of thing. It's just not possible. So be really, really careful there, because you have one conceptualization of why their legs hurt, where there's 20 other causes for that that are much, much more common. So be careful with that at all times. Braun, is a knee or hip injection with Flora only an ultrasound or contrast any better than a blind injection? Yeah, not so much, Braun. Yeah, I think what you're talking about is we have clinics out there that are just using a fluoro machine. They're not using contrast to make sure they are where they say they are. And they're kind of using the fluoro machine as more of a gimmick. So for instance, let me give you a great example of how that goes. So for instance, we teach fellows, and our goal is to get that fellow to be able to do something like cervical facet injections and be very good at that, or at least good enough to make sure that they're definitely safe and they are 99% of the time in the joint, and they can document that and be facile with that procedure. Now that takes hundreds of hours to get to that point, because if you're off by even a millimeter of trying to get, let's say, into a neck facet joint, you're not in the joint. You're someplace else. Usually the stuff is just backing out on the outside of the joint. So, these sub-millimeter or a millimeter type adjustments of the needle, up, down, left, right, forward, back, can get into the joint. But the idea that you could do that without contrast is obviously ridiculous, right? You would never know whether you're into the joint or not, because you've got nothing to confirm that. So I think that's what you're talking about. And you're right. It's not all that much better than doing it blind. It gives you a little bit more information, but it's below the standard of care. Barbara, which months will you, Dr. Schultz, be out for those who need PICL? Dr. Schultz is getting married in September, so wish him well. And I'll be out. I don't quote me on this, but I believe he'll be out for most of September, getting married, honeymoon, all that good stuff. And I will be out from September 19th through October 30th. So those are the times that we'll be out. Yeah, Andres just covered that one. Would you ever be open to regenexx or Iowa facility in Mexico to bring proper medical skills to flourishing umbilical stem cell market? I think the biggest problem, Braun, like I said, is getting a U.S. doctor down there, because the gulf in training between the third world and the first world is pretty big. And in particular for things like this. So if we're talking about just, things that are easy to do, For example, and commonly trained, let's say like a knee surgery, for an arthroscopy, you might be able to find some very competent Mexican physicians. But if we're talking about interventional spine stuff, it's few and far between. It's few and far between, even in developed countries. China, for instance, last time we tried to open something in Beijing, it was like pulling teeth trying to find anyone who had any experience doing interventional spine. Obviously, it's a huge country. Same thing in Europe. We would struggle to find 20 German physicians, for instance, who we would say were really great in interventional spine. We were very, very fortunate, for example, to find 2 interventional spine experts for the UK clinic. So it's just a different world, even in developed countries, let alone in undeveloped countries. Connor, after lots of research on infections such as Lyme and other infections, see a lot of studies showing that these infections can actually cause connective tissue degradation. What's your take? Yeah, not buying it right now, Connor. I don't think we have the data to show that at this juncture. I don't think we have the data to really show chronic Lyme. So I'm definitely the wrong guy to ask about that one. We don't include it, for example, as a cause for CCI at this juncture. So that's where I am on all of that. Let's see, I already answered that one. Andres, is it possible that we'll ever get to the place where patients only need one? I'm assuming you're talking about PICL, but maybe something else. So you'll need to clarify that. But if you're talking about PICL, I would say the one and done rate's about only 1 in 5 right now, meaning 20% of patients are one and done. I think by the end of the year, that'll probably be up to about 30% of our patients because of the dual axis fluoroscopy that we now use, which is extremely rare. But I don't think we'll ever get to only one for the vast majority of people, just because of the nature of what it is we're dealing with and the severity of what it is we're dealing with in most of our, if we're talking about CCI patients. How do you determine the damage to ligaments? So lots of different ways. Digital motion X-ray is a common way. Functional flexion extension MRI. We talked about C1, C2, rotational CT. Again, we're talking about this. Now, obviously, there's lots of other ways to do it in lots of other parts of the body. Marie, what kind of injury could happen if you extend too far from an X-ray? In a normal patient, not much. In someone who's got severe hypermobility, we certainly have CCI patients, for instance, who can't tolerate that. I don't know if they get a permanent injury, but they will certainly get very, very flared up if they do that. How does the lab extract the mesenchymal stem cells from the sample taken? Is it okay if other types of stem cells remain in the sample and are given to the injection process for PICL? Yeah, so there are 2 stem cell fractions within the bone marrow aspirate, and that's a centrifuge technique. There are certainly other cells in there outside of mesenchymal stem cells, including hematopoietic stem cells, including other nucleated cells. Oleg, if you do have tethered cord, do you have to get the surgery before getting a regenerative injection in the spine areas? A. B, are the case when someone can go ahead with PICL without it? C, and is there any way to avoid surgery for those who do a confirmed TC? Well, Oleg, there's no way to confirm TC. That's the problem. So I want to make sure that everyone hears that. There's no way to confirm a tethered cord in the same way that we would confirm other types of diagnoses. So for example, let's say you have patient walks in with numbness and tingling in their thumb. And on their cervical MRI, they've got a right This is my right side here. C5-6 disc herniation, pressing on the exiting C6 nerve. And I can do an EMG nerve conduction study to confirm that there's denervation here. And I can do a transforaminal epidural to get rid of their symptoms. So already we now have lots of different ways to get to that diagnosis, right? We've got a history. We've got a physical exam that matches. We've got an MRI that matches. We've got a test, a diagnostic test that I can do to take away the pain at that specific level. And I know the patient is in bliss. Their pain goes from an 8 out of 10 to a 0 for the duration of the anesthetic. So that's a pretty certain diagnosis that that's what I'm dealing with. That doesn't exist in the world of tethered cord. And that's the biggest problem that we have here. I can't really see it on MRI, certainly not in the same way that I can see a regular tethered cord. There isn't a single diagnostic test I can run, meaning there's lots of reasons for urodynamics to be positive, having nothing to do with tethered cord. And I can't do a diagnostic block to say that I can numb this out and the tethered cord symptoms go away. So that's the problem, is that there's a lot of guesswork in trying to see if that's the issue. So when it comes to C, we can't get there other than a best educated guess. And no, I don't recommend a tethered cord surgery before something like this, right? Because that's more invasive than what we're talking about. So we keep patients safe at all times by doing the least invasive thing that's the most likely to work. We don't jump over and have something much more invasive like a tethered cord release to see if that helps before something less invasive has been tried. That's a little bit like saying, should I get an open heart surgery before I get a stent put in through my vein? Obviously, that makes no sense, right? You would want to get the stent put in and see if that helps. If not, you can always get the open heart surgery. But you wouldn't reverse that. If you reverse that, you'd end up harming a lot of people unnecessarily who would have gotten better with just the stent. So same thing here. We can't jump over a less invasive procedure to get a more invasive procedure and then backtrack, because we're going to hurt a lot of people if we do that. Deanna, do fragile leg patients still see improvements post-PICL? Oh, sure. Yeah, Deanna, I mean, listen, at any given time, probably 1 in 4 to 1 in 3 of our CCI patients, I would put in that fragile leg category. We certainly treat them differently in some ways, meaning that we'll do the concept of less is more with a fragile leg patient is a good one, because that way we can go ahead and try to reduce their exposure to things that might flare them up. And then as they get better, we can do more and more. But yes, I would say a lot of our patients are in that category. And we obviously need to talk to those patients differently and say, this is what you should expect versus somebody else. Oleg, I have mild scoliosis and kyphosis. Would fixing CCI node ligaments fix these postural problems? No, I think, Oleg, you're going to want to deal with your scoliosis and kyphosis either at the same time or before. I mean, to the extent of kyphosis, and to the extent that that's postural on the scoliosis side, there are things like SCROTH, SCR-OTH physical therapy that can help on the scoliosis side. There's curve restoration that can help on the kyphosis side. If you can tolerate those, then that would get done first. Again, less invasive than more invasive. Now, if you've got a lot of CCI, then, for instance, trying to fix the kyphosis you may not tolerate, in which case that may need to be done differently. But you would certainly try the lesser invasive thing, which is going to be SCROTH physical therapy, curve restoration through chiropractic biophysics, to try those before injections, just like you would try injections before you had your cord cut. How far spaced out should PRP injections be? Is just is there a too soon or ideal time frame for mainly disc and CCI issues? Yeah, Lindsay, generally 4 to 6 weeks are good for PRP injections. Can be also 4 to 8 weeks in that realm there. Braun, I went into emergency medicine because I couldn't stand the bullshit they were teaching in PM&R despite primarily being interested in musculoskeletal health. Now, at the advent of interventional orthopedics, I'm captivated, so all I want to do is there a path for me to become one of your fellows without doing another residency? No, yeah, probably not, regrettably. Our fellowship is specific to either PM&R. We've also taken a few family practice docs who had a sports medicine fellowship before they came to us. We are taking our first neurology resident coming up here because he's done extensive work on interventional spine. So we feel comfortable there. So that'd be the kind of thing where you'd really need a lot of work on through things like ASIP and other courses like that in order for us to feel comfortable with all of that, because it's just a lot of stuff to learn. Marie, I recently got relief from nuchal injections after whiplash. I laid back in a salon chair to get my hair washed, and all my symptoms came back. What kind of injury could that be? Yeah, so Marie, as you know, with your head back in those salon chairs, it kind of goes back at a pretty steep angle, usually at the high upper cervical spine there. So is it possible that tore something that was not fully healed? That's possible. It's also possible that there may have actually been injury to the anterior ligaments that went undetected, and the posterior ligaments just kind of helped some of the pain you were having back there. And then it kind of all got aggravated by the chair. So a couple different things that may be going on there. What ligament is damaged that would cause excessive rotation at C1, C2? That's generally going to be the alar ligaments. But there's other ones too. There would be the atlanto-occipital ligaments on the side, C1, C2 intertransverse ligaments as well. The nuchal ligaments could be involved in there, as well as all the different muscles that attach back here. I got specifically better with nuchal ligament injections, but what can I about? Yeah, I think we did that. Could strengthen ligaments help with the herniated discs? I would need to know more about what it is we're talking about and classifying as a herniated disc, but certainly certainly reducing the functional spinal unit instability, which is kind of what you were talking about before, tightening the ligaments of the whole functional spinal unit, may be able to help protect the discs. Okay, guys, so we are at an hour and 18 minutes. We've been doing this for a while here. I am going to start wrapping this one up. And what we were talking about today was the concept of the difference between an intra-articular facet injection versus what people call facet capsule injection, and how they're very, very different. If you want to learn more about that, see the front of this video. I'm pretty sure I'll be here this Friday, and we'll have another topic for you at that point. Also, feel free to leave additional questions. Carol will try to carry those over to the next time. And you all have a wonderful week, and thanks so much for taking the time out of your day to be here. Again, my job is to answer questions, is to educate patients so that patients understand what's wrong with them at a high level, and so they can make good choices, right? It's been my experience that those patients that do their homework tend to get better care than patients who don't take the time to do that. So, you're all out here doing your homework, so that's great. And my goal is to try to educate you as best I can. So have a wonderful week. Thank you.